Hi, welcome to ACC 2021, and I'm joined by Jean-Philippe Collet and Gilles Montalescot to talk about an exciting new study looking at anticoagulation with apixaban in the setting of TAVI, the ATLANTIS study. So I've been waiting to see this study. I'm very excited to hear what you found. Let's start off with you, Jean-Philippe. Talk to us a little bit about the design of the study and the findings, and then we'll turn it over to Gilles to talk about the CT sub-study.
So our primary objective in Atlantis, which was led by our action study group, was to look at whether apixaban was superior versus the standard of care, irrespective of the need for oral anticoagulation, and then to examine whether there was an interaction according to the need for oral anticoagulation. So the patients were stratified at the time of randomization, once they were stabilized, to in the first stratum apixaban versus VKA, and this represented 450 patients. And in the stratum 2, where there were no need for oral anticoagulation, to apixaban versus antiplatelet therapy, and this represented about 1,000 patients. And we looked at the net clinical benefit over 1 year of follow-up, which was defined as the occurrence of death, MI, stroke, systemic embolism, intracardiac or bolus prosthesis thrombosis, deep vein thrombosis or pulmonary embolism, and any major bleedings. So in this endpoint, we had an imaging endpoint, which is the valve thrombosis, which was defined as the visible thrombus on TT or on CT scan, which was protocol mandated between 3 to 6 months, and Gilles will talk about that, and any evidence for hemodynamic valve dysfunction or reduced leaflet motion on the 4D CT scan. So this study was conducted in 4 European countries at 50 sites, and we found that in this real all-comers population, with about 30% of patients who were in need for oral anticoagulation because of atrial fibrillation, that apixaban was not superior to the standard of care, with 150 events in the standard of care group and 138 events. And there were no interaction according to the need for oral anticoagulation. So this is the key finding of the study. And then what?
Go ahead. And what if you just look at the ischemic outcomes on their own without bleeding in the primary endpoint? Was there anything there?
Yeah, there were pre-specified ischemic outcome which were defined, mainly death, MI, and stroke TIA. And there were no difference, but there was a trend for numerically higher number of events in the apixaban versus the standard of care. And this was mainly driven by, death. So, but the bioprosthetic thrombosis as defined in the main endpoint was reduced, and Gilles will talk about that, as well as deep vein thrombosis and pulmonary embolism. So, to, have more, insights, we looked at first safety analysis. And a good news is that safety was similar, irrespective, of what you're looking at. The primary safety endpoint, which was defined as left-threatening bleeds or major bleeds, was similar, and any component of this primary endpoint. And then we looked at stratum, each stratum, what's going on in each stratum. So in the first stratum, which was patients who were in need for oral anticoagulation, of course at higher risk, because higher baseline characteristics at risk, and we found no difference with respective to primary outcomes, secondary efficacy outcomes, safety, and valve thrombosis. So given the ease of use of apixaban, this population may be a good focus for apixaban. So the more difficult population is the stratum 2, patients who are not in need for oral anticoagulation. And as you know, the Galileo trial was halted because of safety issues and no benefit. So what we found in our study is first, same safety. which is a good news. And then with respect to the primary outcome, less events in the apixaban group versus the standard of care, but this was mainly driven by the reduction in valve thrombosis. And then when looking at the pre-specified secondary outcomes, there were no difference with respect to stroke or MI or systemic embolism, but there was a signal towards more non-cardiovascular death in the apixaban versus the standard of care. But this represented, very small number of events, 14 versus 5 out of more than 1,000 patients. And the reason for non-cardiovascular death has nothing to do with any bleeds prior to the occurrence of death. This was more related to sepsis or end-stage renal failure, which led to death of these patients. So this is where we are, with this study. There are, of course, some limitation, but I think that the main conclusions are as follows. First, apixaban is not superior, in the whole population versus standard of care, but this is true in both stratum. The safety is very good in the global population, but also in the both stratum. Subclinical valve thrombosis is decreased, and this is mainly driven by the stratum where anticoagulation was not needed. And finally, as said before, a signal towards more non-cardiovascular mortality in patients who are not in need for oral anticoagulation.
Can I just ask one question, Jean-Philippe? The fatal bleeds, were those cardiovascular events or were those part of the non-cardiovascular deaths?
Well, the fatal bleeds were part of course, cardiovascular events.
Okay, good. Well, so you also had an imaging sub-study. Gilles, what did you find in that study?
Yes, what is unique in this randomized study is that we ask the patients to come back 3 to 6 months after TAVI for a 4D CT scan. Of course, this is an elderly population. Some of these patients were far away from the center. So we got only 800 patients globally coming back for this CT scan, which is a fairly good number when we compare to what we have seen in other studies. So we have a large group of patients with a CT scan performed, and we had a primary outcome for this study, which was the combination of reduced leaflet motion of grade 3 or 4 or halt of grade 3 or 4. And clearly in this study, we see a very strong interaction between the two strata. There is one stratum where nothing happens when you compare anticoagulation with warfarin versus anticoagulation with apixaban, no difference. You prevent valve thrombosis. And there is one stratum where there is a big difference when you compare antiplatelet therapy, whatever it is, to apixaban. And you get here a 50% reduction of valve thrombosis, which is, of course, a significant reduction. And when we look at all the endpoints of this imaging study, presence of thrombus or halt or RLM only, whatever it is, you get exactly the same thing. So we have strong data suggesting that indeed anticoagulation can reduce valve thrombosis. Now, is it important for the patients? It's difficult to say. We have 1 year outcome only in this study. We see a trend. Patients with a valve thrombosis tend to have more events at 1 year, but it's not significant. We may need a longer follow-up. We may need more patients to demonstrate that, but there is a trend. And clearly on valve durability, we don't know. It's too short.
So my question for the two of you, is it too early to dismiss the benefits of NOACs given their benefits on valve thrombosis? Are we underpowered, or do we just have too little follow-up? Do we need bigger studies? Or do we say, well, if there is anything there, it's awful small, so let's dismiss the NOACs? So Jean-Philippe, is it too early, too little to dismiss the NOACs, or do we need more data?
Well, I think that in the stratum of patients where anticoagulation is needed, I think that we have, fairly good data given the ease of use of apixaban, and given, the prior studies like Averroes or Aristotle. So for us, I mean, we can use apixaban in this population, although probably our study lack of power to demonstrate, real things. Now, with respect to, the patients who are not in need for oral anticoagulation, and
right,
is, where the question is, I think that given the good safety profile, this is a good news first. Now, with respect to, ischemic events, like MI or stroke, there is no differences. And the main difference is driven by systemic embolism and valve thrombosis. And I think that the main issue is the non-cardiovascular death. And probably we are dealing with, a very elderly population at risk. The mean age was 81 years. And when you look at, the events which precipitated, the fatal, outcome of this patient, it has nothing to do with cardiovascular events. So I think that using apixaban as a default strategy in this population is not demonstrated for sure. But I think that there are situations where, for example, you have a high risk of, valve thrombosis, and we need to have more data in this, subset of patients. This may be an option.
So Gilles, how well powered were you though to find a difference in clinical outcomes? I mean, here you have a provocative trend showing you reduce valve thrombosis. That surrogate tends to be related to outcomes, Were you adequately powered to exclude a benefit in that second cohort?
Valve thrombosis is one thing. Clinical outcomes is a different animal. Clearly, we can conclude on valve thrombosis, and anticoagulation, whatever it is going to reduce valve thrombosis. And if you think it is important, you need to consider this kind of treatment. In terms of clinical outcomes, we can say that the study is well powered to look globally at clinical outcomes. And we can say that apixaban performs globally well against standard of care. But is it good enough to change practice? I think the data that we have in patients, with an indication for oral anticoagulation are quite good. Safety is exactly the same. Efficacy is exactly the same. And of course, apixaban is much easier to use than warfarin. And the track record of apixaban in AFib is excellent. So most of these patients, after TAVI, needing anticoagulation, they have AFib. So it's probably a good group of patients to get treated with apixaban. For the other patients, too early to say. I think we need more data. We need probably to repeat this kind of study in different populations after TAVI, maybe lower risk patients, for example. So far, we have had 3 big trials after TAVI. One has shown that clopidogrel is not useful on top of aspirin or on top of warfarin, so no benefit of clopidogrel. The other one was stopped prematurely because there was an excess of bleeds and death with rivaroxaban combined with aspirin. And we have this study, and I must say it's probably the best set of data that we have after TAVI, testing apixaban. But again, we need to be very careful. We need probably more data and another study, I guess, especially for the patients without an indication for oral anticoagulation.
Well, amazing work, the two of you. Congratulations to you and your network on doing such a great job, enrolling so many patients and providing some very, very important answers here. I hope you'll go on and answer those other questions again, you two, with some bigger studies. Thanks for joining us here today.
Thank you. Bye-bye now.
Thanks. And thanks to all of you for joining us here live from ACC 2021.